Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling a basal cell carcinoma. As always, let's kick it off with our practice question. The nurse is providing discharge teaching to a client following surgical removal of a basal cell carcinoma on the nose. Which statement by the client indicates a need for further teaching? We have A, I'll start with checking my skin once a month for any new or changing spots. B, I'll wear sunscreen every day, even if it's cloudy outside. C, at least I don't have to worry about skin cancer coming back since this type of cancer doesn't spread. And D, I'll wear a wide-brimmed hat when working outdoors. So again, we're looking for the statement that requires further teaching. Think it through for a second, tuck your answer away, and we will circle back to it at the end of the episode. First, though, let's talk about what in the world is a basal cell carcinoma. It's actually the most common form of skin cancer, but lucky for us, the least aggressive. I want you to think of it as slow and steady. It kind of creeps along the surface of the skin rather than going really deep or spreading elsewhere. To understand how a basal carcinoma develops, first we have to revisit the anatomy of the skin. You guys should know the skin has three main layers. We've got the epidermis, our surface layer, the dermis, and then below that, our subcutaneous layer. Sometimes we hear this called the hypodermis. That is the same thing. Now, the epidermis itself has a bunch of layers, and the very bottom layer of the epidermis is called the basal layer. It's essentially like a factory floor of constantly dividing cells. So they make new cells, they go up and replace older, dead skin cells that just slough off. So now into the disease portion. Imagine that basal layer has been constantly bombarded with UV radiation. UV light damages the DNA inside of the cell, specifically the genes that regulate how that cell grows, divides, and repairs itself. So over time, this like spell check feature of, I'm going to keep myself in check, growing and dividing correctly, that DNA repair system, it stops working efficiently. With that UV radiation, it gets damaged, and damaged cells start slipping through the cracks. They then divide uncontrollably and keep dividing, and voila, a basal cell carcinoma begins to form. So key takeaway, it's in the basal layer of our epidermis, that top layer of our skin. And that's important to know because the basal cell carcinoma is growing locally. It's staying right there in the epidermis and doesn't tend to invade nearby tissue or spread throughout the body because cells don't usually break away and travel through the blood or lymphatic system. They dig deeper into the skin, almost like roots from an expanding tree. So clinically, what are you going to see? It is going to appear on sun-exposed areas. So I want you thinking face, nose, neck, and ears in particular, especially if we're not wearing a hat or putting sunscreen on. The classic description is a pearly papule. So I think that's kind of silly, but it's also fun to say pearly papule. But remember, pearly is kind of like shiny and smooth. It often has rolled, waxy borders. So think of it like a pearl, waxy, shiny, smooth. Sometimes it has a central crater or ulcer, and that could scab or bleed. But overall, it's painless. It's slow growing. Oftentimes, people are going to ignore it at first, thinking like, oh, it's just a pimple. It won't go away. They're not going to think too much of it because it doesn't hurt. It doesn't usually disturb their life. So here's a cool way to remember it. Basal is that bottom layer at the base. Starts deep, but stays local. Cell carcinoma. Carcinoma is abnormal. It's uncontrolled cell growth. And then remember the classic description, pearly papule. It's that shiny bump that you're often going to see in maybe a clinical photo on your exam in your dermatology textbook. Now, even though these rarely metastasize, we want to try and detect them early because if we leave them untreated, they can grow large enough to cause local tissue destruction. And that's especially pertinent if it's around delicate structures, like if it's on your nose or your ears, if it's on your skin close to your eyes. Because remember, the face, the neck over here is often very sun exposed. And if we've got these carcinomas invading into tissue around these structures, they can end up causing problems if we don't treat them. And treatment is focused on just destroying that lesion. We've got a few different options, and we will talk through them in our case study. So, you are going to be working in a dermatology clinic today. Remember, we don't all end up going to work in the hospital. Lots of outpatient opportunities. Derm clinics are bursting at the seams right now. So, that's definitely an option. Just putting it on your radar. So I've got a client for you today, a Mr. Harris. He is 68 years old, and important history, he is a retired landscaper. So he's going to have had lots of sun exposure. That's why we ask people what their occupation is, what they do. We want to get all of that context. Okay, he's coming in for a chief complaint of a spot on his nose that won't go away. You start doing his intake, you're going to kind of get his story. He tells you he noticed it about 8 months ago. He ignored it. It was just a small bump. He said sometimes if he rubbed it, it would bleed a little bit and then scab over, but it just stays there. It doesn't hurt. It just won't go away. And so he figured eventually, it's been almost a year, I'll go ahead and come in. So let's go ahead and go into your exam. You've gotten his history. You take a look. We're going to first inspect. You see it right there on his nose. It's a papule. It's kind of round. So that pearl round bump, it's flesh colored. It's kind of shiny or waxy. And it does have that small central crater. So the center part of that bump or that pearl is kind of caved in. And this is right on the bridge of his nose. Why does that matter? That is one of the most sun exposed spots on our entire body. It sticks out, so it gets more of that sun, and we often don't cover it up. Okay, so you're looking at a sun exposed area. You have a pearly papule from somebody who has a long history of sun exposure. So we're on red alert here for some sort of skin cancer. What do we think has happened? Dig back, think about that anatomy. Think about the disease process. We've got that basal layer of the epidermis with those skin cells that divide and push up. They have been exposed to years and years of UV radiation. This dude being a landscaper, not putting on a ton of sunscreen. He's out in the sun. That radiation is damaging the cells in that basal layer of the epidermis. They are damaged. The DNA cell repair not happening so much. We get abnormal cells. They start dividing. They push up, they divide more, they divide more. They are growing out of control. And that's how we ended up with this basal cell carcinoma. Now, luckily, you can tell Mr. Harris, this is a slow growing cancer. It does not usually spread to other parts of the body, but we do want to treat this because it can be burrowing deeper and deeper into your skin. Like we compared it to those tree roots, and we don't want it to damage tissue in your nose, okay? So it looks, walks, talks, smells like a basal cell carcinoma. How are we going to confirm that 1000%? Well, the dermatologist is going to come in. They're going to get your report. They're going to look at that. They're going to say, yeah, that's a basal cell. Let's do a punch biopsy. They're going to numb up the area right there in the room and just boop, take a small little tissue sample. It takes about 2 to 3 days to get the pathology report back from that. And we can say 100% yes or no, this is a basal cell carcinoma. From there, what is our treatment going to look like? Well, in Mr. Harris's case, we've got a small localized region, and it is a cosmetically sensitive area. We want his nose looking nice. So he recommended something called Mohs surgery. All right. This is what you're going to hear most often. And not all offices do this. So they'll have to go to a Mohs surgeon. But what happens here is they take off a little layer at a time, and then they go look at it under the microscope and they say, oh, yeah, that's cancer cell. We got to get rid of more. Let's take another layer, another layer. Look at it in the microscope. Oh, that's still cancer. Got to take some more layers. It's like peeling the onion of that basal cell carcinoma until we look under the microscope and we say, oh, that's healthy tissue. That is cancer-free tissue. So we're going to remove one layer at a time until all we see is cancer-free tissue. That method is going to minimize scarring and make sure we really get all of the basal cell carcinoma. We're not accidentally leaving anything behind. So that is a Mohs surgery. That's what you'll hear of most commonly. Now, not all clients, depending on the location and the extent, will need Mohs surgeries. We do have some local therapies like cryotherapy, where we freeze it, or topical chemotherapy. There is, in more advanced cases, radiation. I have most commonly seen Mohs surgeries, and that is what I want you to take away from this. Probably even more importantly, though, we do want to educate the client post-procedure. How are they going to take care of that area, and how are they going to prevent future basal cell carcinomas or any type of skin cancer in the future? So first, post-op from a Mohs surgery or a biopsy, we are focused on keeping it clean and preventing infection. So we get an antibiotic ointment. We watch for those signs of infection, warmth, pus, drainage. We need to call right away. And then prevention is, hey, you had skin cancer. You're at high risk for getting skin cancer again. So we need to use sunscreen. We need to wear a hat. Even if it's cloudy, hat and sunscreen, the sun is still out there, you're still getting UV rays. We need to limit time outside, especially when the sun is at its peak. So between about noon and 3, depending on where you live and whatnot, is usually when the sun is at its highest. So let's try to not go outside during those times. Early morning, later in the evening, you're going to get less UV exposure. And when you do go out, sunscreen, hat, etc., etc. We also want to be regularly checking the skin, because if something pops up, we don't want him to be waiting another 8 months to come and tell us, okay? Every month, look for new or changing spots, okay? That's going to help us catch it earlier and have a much more effective and quicker treatment. So with that being said, let's circle it back to our practice question. And again, we're looking at discharge teaching. So everything we just talked about with Mr. Harris, and we want to know which of these statements would require further teaching. Okay. So think about that basal cell carcinoma, everything we just educated on, and hopefully now you'll get to the right answer and understand why. So we have A, I'll start checking my skin once a month for new or changing spots. B, I'll wear sunscreen every day, even if it's cloudy outside. C, at least I don't have to worry about skin cancer coming back because it doesn't spread. Or D, I'll wear a wide-brimmed hat when working outdoors. Which of those require further teaching? I think you know it is C. At least I don't have to worry about skin cancer ever again because, it doesn't spread. That is a misunderstanding. We said, hey, basal cell carcinoma rarely metastasize. It doesn't spread to other parts of the body, or at least not very often. But it can recur locally. And if we leave that untreated, it can cause damage. So we still got to do routine skin checks and prevent reoccurrence. All right. That's monthly self-exams, using sunscreen, wearing a hat. All of those are key prevention factors. So your key takeaway from this episode, really, a basal cell carcinoma, it grows slow. It rarely metastasizes, but we want to catch it early. We want to have ongoing surveillance and sun protection to prevent recurrence and additional lesions. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.